I'd like to thank KCA for putting this, what's becoming a traditional yearly conference. So why this talk? Short answer is, regrettably, most of the trials, if not all of the trials, that you heard about today, earlier this morning and earlier this afternoon, focus on recruiting patients with the most frequent histology of renal cell carcinoma, and that's conventional type. But there are up to 20% of patients with advanced renal cell carcinoma who have these rarer types. And this is a diverse group of tumors. It's not one disease, it's a heterogeneous disease. So I'd like to show you what has been done so far and then what is the glimpse of hope moving forward. So I'm sure you heard this morning about conventional type renal cell carcinoma. It is the most frequent type. About 75–80% of patients with advanced RCC have this type. And about 20%, as I said, have these diverse histological subtypes. Papillary type 1 and type 2 constitute about 15%. Now, in patients who don't have metastatic disease, just get nephrectomy for primary tumor, it is estimated that about 10% will have papillary type 2 and 5% will have papillary type 1. But in my experience, when patients develop advanced disease, recurrence after the nephrectomy, or present with advanced disease at initial diagnosis, the majority of papillary RCC is the type 2. Chromophobe is less common than papillary. Again, we'll talk about this. It's a more indolent, means it is less aggressive, progresses slowly than the others. But when it is metastatic, it is unfortunately incurable. Collecting duct is, again, another aggressive type of non-clear cell RCC. And renal medullary is a very close type, very similar histologically to collecting duct, but it is unique in that it affects African Americans, typically at a young age, who have sickle cell trait. We'll discuss this a little bit as we go. Translocation is a newly diagnosed or newly recognized entity that is mostly present in young people, in adolescents, and young adults. We are now conducting molecular research on this unique entity. There will be about 5 to 7% of patients who will have this report signed by the pathologist as unclassified RCC. And it is really a waste basket diagnosis because it reflects our inability or limitations in really pinpointing the diagnosis. So we refer to it as unclassified. As our molecular insights advance, we will be able to classify the unclassified into more unique and distinct types. And there are some rare cases as mucinous tubular and spindle cell, MTS, thyroid-like follicular carcinoma is also a very rare type. Oncocytoma is usually benign, rarely metastasizes, but it's one of those non-clear cell RCC types. Now, I put sarcomatoid dedifferentiation here, and I will discuss this because I think it presents challenges to the treatment of patients with this problem. Sarcomatoid dedifferentiation occurs with all subtypes of RCC, the conventional, the clear type, as well as the non-clear type. And it portrays an aggressive behavior. So this is what papillary type 1 RCC looks like under the microscope. There is an inherited syndrome that's characterized by mutation, germline mutation of the c-Met oncogene, and it results in constitutive activation of the c-Met receptor. Now, it is estimated that about 10 to 15% of tumors that are sporadic, that are reported as papillary type 1, will have this mutation in the tumor. The other, papillary type 2, there is also an inherited syndrome that's characterized by germline mutation of a tumor suppressor gene that's called fumarate hydratase gene. Individuals with this inherited syndrome have, in addition to renal cell carcinoma, leiomyomas. Females have leiomyomas of the uterus, and both sexes will have leiomyomas of the skin. It is referred to as HL-RCC, hereditary leiomyoma RCC. Now, sporadic tumors obviously are much more common than inherited syndrome in both type 1 and type 2 papillary RCC, and the molecular knowledge about this, molecular characteristics, are not really well characterized. This is chromophobe, as I alluded to earlier. It is usually indolent compared to the others, unless it is associated with sarcomatoid features where it becomes virulent. There is an inherited syndrome also associated with this type, and it's called Birt-Hawk-Dubé syndrome. There are mutations in gene. Folliculin is one of these. Collecting duct carcinoma of the kidney is highly aggressive, and it's a disease that's a hybrid between renal cell carcinoma and transitional cell carcinoma of the renal pelvis, which is TCC, transitional cell carcinoma of the pelvis, behaves like bladder cancer. So that's why you will see features of both RCC and TCC in patients who have this tumor. It is invariably an aggressive type of cancer of the kidney and invariably presents at an advanced stage. Renal medullary, as I said, is very closely associated with collecting duct, and as I said, it affects young African American with sickle cell trait. We already covered the unclassified. We talked about this. This is how it looks like under the microscope. Again, with refinement of our technology, we will be able to subclassify more the unclassified. Translocation, as I said, it's typically a disease of young female. Patients present with advanced disease, with at least the adolescents and the young, with extensive lymph node metastasis, and TFE3 protein product of the translocation has been studied. This is what sarcomatoid RCC looks like, and again, as I said, it's associated with both the clear cell and the non-clear cell histologies. Chemotherapy plus target therapy trials are ongoing, but the prognosis remains guarded. So this is historical. I'll be showing you some historical data from the pre-target therapy era. This is when interferon, interleukin-2, and chemotherapy were the mainstay of therapy for patients with advanced RCC. This is a retrospective study from Memorial in 64 patients with non-clear cell histologies, and the majority were reported as having collecting duct, then chromophobe, papillary, and unclassified. The median survival was about 2.5 years in patients with chromophobe RCC, but worse in patients with collecting duct and papillary. As you see, very dismal median survival in patients with advanced papillary. Again, this is pre-target therapy era. We looked at our own experience. These Kaplan-Meier curves represent patients treated with, the ones here are the ones patients treated with the conventional, and this is the group with the non-clear cell, the non-conventional. Survival is about 10 months median for the patients with non-clear cell versus patients with clear cell. Again, patients who were treated in the era of immunotherapy. So what about the current therapy of patients with advanced non-clear cell RCC? I think you may have already heard about this earlier from speakers this morning. Temsirolimus was tested in a phase 3 trial in patients with advanced poor risk RCC. These are patients who have multiple risk factors, such as anemia, compromised performance status, hypercalcemia, high serum LDH, and patients who are randomized to receive either Temsirolimus, the mTOR inhibitor given intravenously weekly, or interferon as a comparator, or the combination of these two. Survival was the primary endpoint of the study. 20% of those patients had the non-clear cell histologies. And the results were in favor of Temsirolimus. The median survival with Temsirolimus was 10.9 months versus 7.3 months median survival for patients treated with interferon, an improvement of 49%. So I think it's fair to say that for patients who have advanced non-clear cell histologies with poor risk features, Temsirolimus is a reasonable option as first-line therapy. This is a retrospective study conducted and published by the French and the Cleveland Clinic investigators looking at Sunitinib and Sorafenib. And you heard, I'm sure, from earlier speakers about these two agents. The majority of these patients had papillary, 41 patients, 77%, versus 12 patients with Chromophobe, 23%. I think the take-home message from this retrospective analysis is that there was no central pathology review to really confirm that, in fact, these patients had these pathologies that were reported. And there was no central independent radiology review to confirm the responses. But what the investigators reported is a decent median progression-free survival in patients with papillary, 7.6 months. Obviously, shorter than what we see in patients with the conventional type RCC. For Chromophobe, the median PFS was even better at 10.6 months. Again, retrospective study, patient selection biases are inherent to this. The French conducted a phase 2 trial with Sunitinib in papillary RCC, and these are the results. The majority of these patients had type 2. As I said, this is the most frequent type of papillary RCC in patients with advanced disease, and they only observed one patient achieving a partial response among 23 patients with type 2. No patient among 5 had, with type 1 had a response. The Memorial Group published their experience. This is a single-arm phase 2 trial. Unfortunately, the trial was close to patient accrual prematurely because of a slow accrual, and that's basically brings up the point that Dr. McDermott mentioned earlier about the importance of participation in clinical trials. And if we don't really have robust participation in clinical trials, we end up with trials that take a long time, and then unfortunately many of these close before the endpoint is realized and before we really can make robust claims about the results. But among 22 evaluable patients, 8 had papillary RCC, 5 unclassified, 10 were reported as having others. Only one patient had a partial response. That was a patient with unclassified RCC. The median progression-free survival, 5.5 months, basically half of what you expect or what we observe in patients with the conventional histology. And in patients with papillary, again, median PFS was 5.6 months. We conducted our own study with Sunitinib, and this is a one of the largest trials of Sunitinib in or any target agent in non-clear cell RCC. The median age is typical of clinical trials, about 60. We had patients with different risk groups, some good, intermediate, and poor. 2/3 of our patients had prior nephrectomy, and we allowed prior systemic therapy, and 8 patients had prior systemic therapy. We did not exclude patients who had brain metastasis if brain metastasis was controlled. This is the breakdown of the different histologies in that phase 2 trial. Papillary constituted about half of the patients, 27 of the 57 patients. 8 had unclassified, 7 sarcomatoid, 5 chromophobe, 4 renal medullary, 2 collecting duct, and there was one case of each of these rarer tumors. This is a summary of the efficacy data with a follow-up of median follow-up of 21.7 months. We observed 5 responses. That's less than 10%. 2 of these responses were in Chromophobe, so 2 out of 5, 40%. That seemed to mirror image the experience with conventional histology. And then there was 1 patient each who had a PR among 25 with papillary, 1 out of 8 with unclassified, and 1 of 7 sarcomatoid. The important points to mention about this trial is that all the slides, all the pathology specimens were reviewed by 1 single GU pathologist, and all the scans, baseline and subsequent scans on therapy, were reviewed by a single blinded radiologist. So we are pretty confident of the results that we report here. The progression-free survival and the overall survival data are represented in this slide. For 55 patients evaluable for response, median PFS was 2.7 months. Obviously, very disappointing, and you see the confidence interval is quite narrow, meaning that we believe that this reflects reality. For the 25 patients with papillary RCC evaluable for response, 2 were not evaluable for response. The median PFS was dismal, 1.5 months. Again, narrow confidence intervals. For all 57 patients, the median overall survival was 16.8 months, perhaps reflecting maybe the patients lived longer because they received maybe subsequent therapy that may have benefited from more than they benefited from Sunitinib. For the patients who had papillary RCC, the median overall survival was 12 months, 12.5 months. Now, the Koreans reported their experience at ASCO last year. They had a completely different experience. They showed results that were more consistent with what we see with conventional histologies. This was a single-arm phase 2 trial. A smaller number of patients, 29 patients, were enrolled on that trial. The vast majority, 84%, had prior nephrectomy. They had some patients who had poor risk. About a quarter had poor risk. And the majority of the patients were papillary with only 4 Chromophobe and 4 others. And here are the results for patients, for the overall cohort of 29 patients. 38% had partial response, and about half had stable disease. This is median time to progression of 6.4 months, and an estimated median survival of about a year and a half. 1 treatment-related death, and the authors did not find any significant difference among the histological types in terms of response. Clearly, different trials done in different continents, different ethnic backgrounds, I think raises the question, are the Koreans different? And we talk about pharmacogenomics and other factors that could contribute to the difference we see in response to therapy with the same disease. I think an important caveat to mention is that the Koreans, this was a multi-center trial, and the pathology was not centrally reviewed. So they had different patients from different hospitals in South Korea, and I think you could argue that the pathology was not confirmed, and there may be some clear cell cases among those. There is now an ongoing trial with Everolimus, the mTOR inhibitor, which I'm sure you heard about earlier today. It's called the RAPTOR study. It's occurring in Europe at multiple sites. It's a single-arm study of Everolimus in patients with papillary RCC. The primary endpoint of the trial is progression-free survival at 6 months, and secondary endpoints are disease control rate, objective response rate, and median progression-free survival and safety. There are 2 randomized phase 2 trials of Everolimus versus Sunitinib, one led by Duke and is recruiting patients from Canada and the United Kingdom, and one of our own led by our institution with contributions from the Harvard Consortium. The 2 trials are very similar in design, except that the Duke study, which is called the Aspen trial, does not have a crossover at progression with first-line therapy. This is the schema of treatment for the ESPN trial, Everolimus versus Sunitinib, in prospective evaluation in non-clear cell RCC. Patients with non-clear cell RCC after stratification, whether they have papillary or the other non-clear cell subtypes, will be randomized to receiving either Everolimus, 10 milligram a day, or Sunitinib at the standard dose and schedule of 50 milligram daily, 4 weeks on, 2 weeks off. They stay on therapy until they have progressive disease. At progression, they cross over to the other agent they did not receive in the first-line therapy. Now, moving forward, I hope the future will be brighter than what I showed you. And I think there are a couple interesting trials that I would like to present to you, and then what hopefully the future will bring. EGFR is being recognized as an important pathway to block in several malignancies, epithelial malignancies, and kidney cancer is one of them. Evidence for EGFR overexpression or aberrant function has been reported in many of these epithelial malignancies, and there is a rationale for EGFR inhibition in RCC. And this was from preclinical in vitro work in cell lines, in renal cell carcinoma cell lines. This was work done by Dr. Mendelsohn, our former president here, where they transfected VHL into VHL negative cell lines and showed that restoration of response to the antibody against EGFR, the C225 antibody or cetuximab, was blocked the tumor growth, indicating that presence of wild-type VHL is required for effective EGFR blockade. This constituted the hypothesis for this phase 2 trial conducted by Southwest Oncology Group and published 3 years ago. They had 52 patients enrolled from 27 SWOG sites and 2 ECOG sites. 7 of those 52 patients were ineligible for different reasons, and only 45 patients were evaluable. And this is the efficacy slide with a median follow-up of 21 months. There were 5 partial responders. 4 were confirmed, 1 unconfirmed. This is an 11% response rate with a wide confidence intervals, as you see. The overall disease control rate, which was a secondary endpoint of the study that included partial responders as well as patients with stable disease, this was 64%. The probability of freedom from progression or treatment failure at 6 months was 29%. And the estimated fractions at 2, 4, and 6 months of patients who were stable or responding were 71%, 44%, and 31% respectively. Overall survival at the estimated 6-month overall survival was estimated to be 87%, and the median overall survival was estimated to be 27 months. This is pretty encouraging, but again, a single-arm study of 45 patients where you could bring up patient selection biases. So these are the study limitations. They didn't look at tumor grade. We know very well that papillary RCC is not one disease, as I mentioned, and that patients with tumors that have high grade have more aggressive disease than patients with lower grade. That was not looked at in the study. Also not looked at, they did not differentiate. They did not really characterize how many of those patients, of the 45 patients they recruited, had type 1 and how many had type 2. No comment on what second-line therapies these patients might have received later after receiving Erlotinib on this trial that could have confounded the survival and showed the survival to be better than what we've been accustomed to see. No mention of how many patients had prior nephrectomy or metastatectomy prior to enrollment on this trial. And then there was no correlation at all with EGFR expression and PFS or overall survival. And again, there were several patients who did not have central pathology review. So my take on Erlotinib in papillary RCC is that Erlotinib appears to have some activity in papillary RCC, and it is Erlotinib is overall a well-tolerated agent, but is inhibition of this pathway beneficial to all patients with papillary RCC? That remains to be seen. Which subgroups of papillary RCC would benefit most from these EGFR inhibitors? I think the story here is similar to the story with non-small cell adenocarcinoma of the lung, where EGFR mutation has been linked to best response among these patients. Which molecular markers will be predictive of response will await to see. I think only through a larger prospective randomized trial we will be able to answer many of these questions. And I believe we really need to have an ongoing a future trial looking again at Erlotinib, which is called Tarceva. That's the brand of it, Tarceva, in patients with papillary RCC. Now, an interesting pathway, which I'm sure you have seen this morning, is the c-Met pathway. This is a pathway that seems to be operative in patients with, some patients with papillary RCC. You see hepatocyte growth factor is the ligand that signals through its receptor, the MET receptor, and causes downstream effects. There are several agents in the clinic in phase 1 and phase 2 that are targeting this pathway. This is an antibody against the hepatocyte growth factor by Amgen. There is another drug similar to this that targets the ligand that's from Avio. And then there are several of these small molecules tyrosine kinase inhibitors that block the pathway here intracellularly. I think of these, I will focus in my talk on one that's called now Sorafenib or XL880. This is a phase 2 trial that was conducted at multiple centers in the US. There was a biomarker initiative in this trial to study the effect of MET and how it was modulated and correlate MET with outcome. We already covered the oncogenic events in papillary RCC are unknown, but do not involve the VHL-HIF-VEGF axis. Activating mutations of the MET gene have been identified, as we said already, in hereditary papillary RCC and about 10% of sporadic papillary RCC. 75% of sporadic RCC may have duplication in chromosome 7 at the location of MET, which enhances MET signaling. What is Sorafenib? Sorafenib is a multityrosine kinase inhibitor, but predominantly it blocks two pathways that may be critical in patients with papillary RCC. This is the c-MET pathway and the VEGFR2 pathway. It was shown to have activity in xenograft models, and in a phase 1 trial of this agent, 2 patients with RCC had durable partial response. One lasted more than 48 months. Based on this, encouraged by this and the rationale of blocking the MET pathway in papillary RCC, a phase 2 trial was then conducted. This is the study design and treatment plan with Sorafenib. There were 2 dosing cohorts, one intermittent, 240 milligram a day, given for 5 days every 2 weeks, and then a daily cohort of giving the drug at 80 milligram a day. There was the important thing about the trial and its design is that patients were stratified by whether they had evidence of germline mutation of the MET oncogene, or they had other MET pathway aberrations, such as somatic MET mutation, gain or duplication of chromosome 7, and or 7q31 amplification. The study was designed to accrue at least 30 patients per dosing cohort. The primary endpoint was objective response rate, and secondary endpoints included progression-free survival, overall survival, safety and tolerability, and then pharmacokinetic and pharmacodynamic markers. And as I said, correlation of the MET status with outcome. This is a summary of the efficacy, looking at objective response rate. 13.5% had partial response. It was the same with the 2 cohorts, whether the intermittent dosing or the daily dosing. Duration of response was 1.5 years, and 88% of the patients had disease stability, either partial response or stable. You're looking at the Kaplan-Meier curves of progression-free survival. In blue is the overall cohort of 74 patients. In yellow, patients treated with the intermittent dosing, and in red, patients treated with the daily dosing. As you see, compared to what we discussed earlier with Sunitinib and others, this is very encouraging to have about 9 months median PFS in these patients. Secondary endpoint, overall survival, median not reached across both cohorts, and about 70% of patients were alive at 1 year. This is a frequent thing we like to show, which is waterfall plot showing best percentage change of tumor from baseline. And you see here 50 patients had tumor shrinkage among the 68 patients. So even though the response rate was low and did not meet the primary endpoint that the investigators set, fixed it at 25% to make it interesting and move forward with this drug. So 13.5% was about half of what they thought, what they were aiming at. When you look at the tumor shrinkage, I think this is impressive to see this kind of tumor shrinkage in a disease where we really don't have established therapy. Now, I think this is a very important slide because it illustrates, it's a proof of concept that when you target a molecular pathway that drives a disease, such as the type 1, where you have germline MET mutation, 5 of 10 patients, that's 50%, had partial response. Now, when you look at sporadic cases, only 1 of the 5 with the somatic MET mutation had a partial response, that's 20%, and the others did not respond. So I think this represents a progress, a path forward to try to bring this company to sponsor a large trial testing this in a large number of patients. I told you I'll mention sarcomatoid because it presents challenges to our management of patients with sarcomatoid RCC. Just briefly, this is a disease that the backbone of treatment for sarcomatoid remains chemotherapy. People have looked at adding target therapy. This is the backbone of the treatment, is 2 cytotoxics. This is a trial conducted by ECOG, was published in Medical Oncology Journal recently, but basically the responses and the efficacy were not very encouraging. Median PFS less than 4 months, survival less than 9 months with chemotherapy for these patients. There is an ongoing trial at the Harvard, by the Harvard Consortium, looking at combining gemcitabine and sunitinib in patients with either sarcomatoid RCC or patients with poor risk disease. This was presented with preliminary results 2 years ago at ASCO GU, and the results, there was a 25% partial response in 3 patients, but again, looking at the time to progression, 4.8 months, and then there was a high toxicity rate with 25% of the patients dropping because of toxicity. The trial is ongoing. They have now reached 80 patients total accrual on this trial. This is our own experience here. We recently closed this trial with 34 patients accrued, looking at combining gemcitabine, capecitabine, 2 cytotoxics with bevacizumab, the target agent blocking VEGF. Again, our results are in keeping or in the ballpark with the other trials. So summary, non-clear cell RCC presents a diverse group of rare tumors with still no established effective therapy, unfortunately. This is why I believe patients with advanced non-clear cell RCC would be best treated on clinical trials, as you heard from Dr. McDermott earlier. There is no place that this is more urgent than in patients with non-clear cell RCC. Because, as I said, these other drugs that are already FDA approved and work for many patients with conventional, unfortunately, do not work as well in non-clear cell. But I think, the point to underline is the importance of collecting tissue. I heard one of the, a question raised about the importance of tissue collection. This is crucial to try to really advance our knowledge. Now, I want to finish with a glimmer of hope. As I always try to in these presentations where unfortunately we don't have always good news. This is a patient whom I saw 10 years ago from the Valley. For people who are from Texas, they know where the Valley, Rio Grande Valley. This is a patient who had conventional type RCC with sarcomatoid, who had his nephrectomy in the Valley, came 2 months later with metastasis to bone, lungs, and lymph nodes. And I'm showing you the scans. Pedro, his name is. Pedro came in with a large family of 50 members in a wheelchair. He had compromised performance status. He was requiring transfusions weekly. He had what we call constitutional symptoms with weight loss and sweating, as some of the patients with RCC experience. And this is 10 years ago when we didn't have any of these therapies. Pedro wanted to be treated. His family supported him. And we treated him with what we had at the time, and that was chemotherapy with 5-FU, gemcitabine, and low-dose interferon. Well, as you see, this next to your right, the scan from recently, Pedro is alive and doing well, in complete response. 10 years later, he's celebrating 10-year anniversary beating kidney cancer with his family. So I want to end this because I believe it is important to keep the hope alive, even in an arid desert. We salute you, the patients, and the families. You are the heroes who inspire us to continue our research to make RCC history. Thank you.